We are live.
Good evening, everyone, and welcome to the iFocus online classes. And here I welcome you all to the episode 396 of the iFocus online. And we are on the 10th episode of Cataract module. I would like to welcome our chairperson, Dr. Paresh Vaidya sir, and the speaker for this session today, Dr. Shilpi Diwan ma'am, who is currently working in Center for Sight Eye Hospital in New Delhi. The topic for discussion today here is pre-operative preparation for cataract surgery. Our speaker, Dr. Shilpi Diwan, a brief introduction to her. She is a senior consultant and a surgeon for cornea, cataract, and refractive surgery at Center for Sight Eye Hospital, New Delhi, and she's been working here since almost a decade now. She has done a post-graduation and senior residency from the prestigious King George Medical College, Lucknow, following which she pursued a fellowship in cornea and refractive surgery from Arvind Eye Hospital in Madurai. She has an experience of working at various hospitals like Venu, Vasan, and Center for Sight. Her main areas of interest are lamellar corneal transplant and limbal stem cell transplant, ocular surface reconstruction, refractive surgeries, and management of corneal infections and corneal ectasias. I welcome Dr. Paresh Vaidya sir and Shilpi ma'am for this session. And we also have two students who have joined in today. Dr. Debashish, who is a postgraduate at AIIMS Bhubaneswar, and Dr. Saksham, who is a postgraduate at Guru Nanak Eye Center, Maulana Azad Medical College. So, Dr. Paresh Vaidya sir, over to you for your comments before we start the session, sir.
Thank you, Dr. Pranita. Thank you very much. Good evening, all. And I welcome Dr. Shilpi and all two students, those who are joining. I think so. All of you know that every surgery needs a perfect pre-operative preparation before going for any surgery. And as when we are talking about cataract surgery or any intraocular surgery, it requires utmost sterilization as well as pre-operative preparation before we do any intraocular surgery. Because we know that when we do any intraocular surgery, it's all or none law for us. Because if it goes any one step wrong, then it ends in a very disastrous condition. So I think so today's topic for all of us is very important because each step in a pre-operative preparation is very important for us, and we should follow all these steps very meticulously. And these all steps are very important. Why? Because it covers at all levels. It not only at a doctor level, but it's starts from the prescription of a pre-operative medicine to the pre-operative level at autoclave sterilization, to the operative scenario, to the assistance, to the all managerial things, and everything is required in this part. So I think so Dr. Shilpi will cover all this pre-operative assessment as well as pre-operative medications, intraoperative, how to handle all these patients. And we will have a good discussion also, I think so, after this presentation of Dr. Shilpi. Dr. Shilpi, welcome, and over to you for this PPD presentation.
Thank you, Dr. Vaidya. Thank you, Dr. Pranita, for the kind introduction, and good evening, students. Good to have you here. So without any further delay, I'll start the topic and I'll start sharing my screen right now. So is the presentation visible to everyone?
Not as of ma'am.
Not so.
Yes, ma'am. We can see the screen.
Right.
Yeah.
Okay.
Perfect.
Fine. So the topic for today, as Dr. Vaidya just now said, it's a very important topic. And as a surgeon, we all strive for perfection and we want to perfect outcomes for the surgery. And for the same reason, we have to be very meticulous and take all the precautions and prophylaxis for infection, increased inflammation, and raised IOP after cataract surgery. That is the specific topic for today. So, so first of all, we'll be talking about infection because that is the most important and dreaded scenario which any cataract surgeon or any surgeon can face. So post-cataract surgical infection can present as a surgical incision site infection, which can be corneal, limbal, or scleral. In case there are any sutures, it can present as a suture abscess as well. There can be reaction in AC or hypopyon. And lastly, the most dreaded complication is endophthalmitis, which is defined as the inflammation of the inner coats of the eye due to the microbial infection and exudation within the fluids of the eye, that is the anterior aqueous and vitreous as well. Various studies have been conducted which show that the incidence rate of endophthalmitis after cataract surgery varies from 0.02 to 0.68. However, there are multiple factors which affect the incidence rate. For example, the setup of the surgery, whether it is an institutional surgery or a mass level surgery arranged in some camps, or the levels of the surgical training of the surgeon, duration of the surgery, the prolonged surgery cases are at a higher risk of developing any chances of infection. And the culture and sensitivity from these cases, most of the case studies and the long data we have, they say that up to 90% or more than 90% of infections are caused due to gram-positive organisms. And according to the EBS study, up to 70% are because of the coagulase negative streptococcus. So now we have to see that when we are dealing with the infection in case of cataract surgery, where can the infection come from? First and most important and the commonest is the ocular surface flora of the patient itself. Whatever flora is, whatever microbes are residing on the surface of the cornea, be it the eyelashes, roots of the eyelashes, lid margins, conjunctival cornices, or the ocular surface in the form of conjunctiva and cornea, they can be introduced into the anterior chamber at the time of surgery and can lead to infection. Secondly, any of the things which enter the anterior chamber during the surgery in the form of the surgical instruments, irrigating fluids, or OVDs, or even IULs, they can lead to infection if the sterilization chain is broken, if all the protocols for the sterilization are not followed meticulously. So when we are talking about infection prophylaxis, it can be broken into two parts. First thing is to make sure that the surface on which we are operating, that is sterilized. And the second is, in case if it so happens that some microbes enter the anterior chamber, we have to neutralize it at the conclusion of the surgery and in the post-op period. For the sterilization of the ocular surface, there have been multiple steps which can be followed. First of all, it is a pre-operative topical antibiotics, which is a topic which has been a bit of controversy, and there are no general guidelines and not a consensus worldwide about this. We'll be discussing that. Second is the povidone iodine cleaning and dripping of the eyelids and the skin around the eye, and also installation of povidone iodine into the conjunctival cul-de-sac, and sterile lid draping, isolating the eyelashes. So for the purpose of learning and explanation being made easy, I'll divide the prophylaxis into pre-operative, peri-operative, and post-operative. Going on to the pre-operative. Pre-operative, most importantly, there are systemic factors and local factors. Coming to the systemic factors, most important is the glycemic status of the patient. If the patient is a known diabetic, the fasting blood sugar less than 140 mg/, and postprandial or random should be less than or equal to 200. Any glycemia more than this, patient should be deferred. And also it is important that there shouldn't be a very sudden decrease in the glycemic level of the patient. It shouldn't be that the patient takes a BD or TDS doses of insulin and reduces the blood sugar just to produce a report. So you have to see a long-term status, the glycemic control of the patient. Then only we can post the patient for the surgery. Secondly, the reports which we take for this check for the surgery should be recent, preferably within 1 week. There should be no obvious other foci of infection in the body, like any kind of cellulitis, boils, or abscess in any part of the body. There is always a risk of hematogenous spread of infection. There have been reports of endogenous endophthalmitis occurring in such cases. Coming to the local factors, very important thing is to check the lacrimal drainage system of the patient. It should be patent. The Roplast test or syringing should be done to ensure that there is no blockage and there is no regurgitation of the purulent material into the conjunctival sac. But important thing to remember that the Roplast or syringing should never be done on the day of surgery. Basically, no touch procedures should be done, no contact procedures should be done on the day of surgery. That is one thing very important. Second, coming to the lids, any kind of lid diseases, be it a meibomian gland dysfunction, allergic dermatitis, or any kind of other infections, that should be treated thoroughly and properly before taking the patient for cataract surgery. Another important thing which comes to my mind is herpes simplex virus disease. If the patient has any kind of herpetic disease, whether it was a keratitis, keratouveitis, or trabeculitis, anything which patient has one or multiple episodes, it should be treated properly, and there should be the recommendation is that there should be a waiting period of at least 3 or more months after the complete resolution of the HSV disease, and the surgery should be done only under the systemic antiviral prophylaxis. This is done to prevent the reactivation of the HSV disease in immediate post-op period, because as we know, the surgery is a kind of, after surgery, it is a physiological stress for the body and there is a local immunosuppression. And also we are giving topical steroids, so that can precipitate or aggravate this disease. Next, if the patient had any episode of conjunctivitis, whether bacterial or viral, patient should be treated completely. And before taking the patient for surgery, there should be no obvious signs on slit lamp examination, no obvious signs of any infection, no congestion, no discharge, any kind in the conjunctival sac. And patient should be taken for a conjunctival swab culture and sensitivity. Only after we get a negative culture sensitivity report, patient can be posted for the surgery. Pre-existing dry eye is another important factor which is very often overlooked. It should be treated properly. Patient's ocular surface should have adequate moisture and luster, because in case the ocular surface is compromised because of the dry eye, there is a possibility of a lot of corneal erosions and which might compromise the post-operative epithelial healing. And also because of the post-operative steroids, there is a high risk of infection in those cases, which we do not want. In cases of severe dry eyes, punctal plugs or punctal cauterization can be considered before taking the patient for a cataract surgery. The next and a very important factor is use of pre-operative topical antibiotics, which we'll be discussing in detail. So pre-operative antibiotics, when we talk about the antibiotics which to start before the surgery, two important questions: what is the antibiotic we choose, and what is the duration, or when should we choose? As I told you, there is no consensus and there is no long-term data or any kind of big study to show that which antibiotic should be started and when it should be started. So our decision making should be affected only by the scientific facts. So the rationale behind using pre-operative antibiotic is to sterilize the ocular surface before we make any incisions onto the surface during the surgery. So the characteristics of the antibiotics should be that it should be bactericidal, not bacterostatic. It should have a broad spectrum of activity, and especially it should be active against the gram-positive organisms, because from all the data we have, all the medical data, we know that most of the major percentage of the endophthalmitis cases is because of the gram-positive organisms. A small percentage is because of the gram-negative organisms like Haemophilus or Pseudomonas, though it is a very disastrous thing to have, and also even rare fungi and nocardia. It should be a fast-acting agent, and it should have a good ocular tissue penetration, the antibiotic we choose, and a very low ocular surface toxicity. So all these characteristics, if we see, they point towards fourth generation quinolones, which we are currently using for the pre-operative prophylaxis. Now, again, when to start the antibiotics? As I said, there is no consensus. Some surgeons completely forego this step. They don't believe in giving pre-operative antibiotics. But currently what we practice is at least 3 days before the surgery, we start fourth generation fluoroquinolone in QID dosages. And not longer than that. A longer period of preoperative antibiotic is not recommended, definitely not recommended, because we do not want the emergence of resistance to any of these higher antibiotics. Because these are the antibiotics which we have in our armamentarium to treat the serious kind of infections. And a rampant use of these antibiotics preoperatively for a longer period is definitely not recommended. So this, and otherwise, some surgeons also start this antibiotic on the day of surgery, maybe 2 hours before the surgery. They can give 3 to 4 doses at the interval of 20 minutes or so. That can also be done, but again, there is a chance that it has to be carefully done so that the installation is avoiding the cornea, because we do not any kind of corneal epithelial damage on the day of surgery. So these are the 2 protocols roughly which most of the people are following. And commonly, some people also prefer aminoglycosides, but again, as we know, aminoglycosides have a propensity to cause ocular surface toxicity. So if the patient develops that would be not good for the planning of surgery. We'll have to postpone the surgery. And moxifloxacin is what, gatifloxacin or moxifloxacin, quinolones are what we are using presently. Now coming to the peri-operative measures. So peri-operative measures have a huge lineup of things: OT sterilization protocols, instrument sterilization, surgeon preparation, patient or the part preparation. OT sterilization protocols and instrument sterilization is a very, very important part of the thing, but it is a very vast topic and beyond the scope of this topic. So it can be covered, it will be covered definitely in different classes. But one has to make sure that all the protocols are followed meticulously. We cannot afford any breach in any of the protocols. Now, coming to the surgeon preparation, the surgeon preparation involves a very thorough and standard scrubbing technique with using povidone iodine. It has been shown in very large database studies that surgeon scrubbing with povidone iodine is a very effective method to reduce the post-op infections. At least 3 minutes of scrubbing is advised. Standard gowning and gloving procedures should be followed. Apart from that, any OT personnel, the scrub assistant, the scrub nurse, and the floor staff, they all should be covering their nose and mouth with the mask. They should be properly dressed in the OT dresses. And any person with the obvious URTI, coughing or sneezing, and or any kind of infection in the eyes like conjunctivitis, red eyes, or watering of the eyes should be barred from entering the operation theatre. So the general guidelines we have to follow and be very careful, because we never know where even a minor lapse in following these protocols can lead to serious outcomes, which we would avoid at any cost. Coming to the patient preparation, now, as I previously said, no type of contact procedure should be performed on the day of surgery. Most importantly, biometry using a A-scan probe should not be done. Any Roplast testing should not be done. Syringing should not be done. Okay? And the sterile preparation of the skin surrounding the eye should be done very meticulously. And after that, installation of povidone iodine onto the cornea, avoiding the into the cul-de-sac, avoiding the cornea should be done approximately 3 minutes before the surgery. Direct installation of cornea has to be avoided. As I told, it can lead to the corneal epithelial damage, which we don't want. And then application of a sterile drape. We can see here. The draping with betadine is done from inside out, never from outside out. The cotton swab which has touched the peripheral skin should not be brought back. If you have to do it again, take a second swab. And the drop installation should be done away from the cornea. Preferably plastic drape should be used, and use of an eye speculum is must. And the draping should be done such that, as we can see in this image, the eyelash should be totally isolated from the surgical field, from the ocular surface. Because as we know, the root of the eyelashes and the lid margin, the lash line entire, is a place which harbors a lot of microbes, and we want to isolate it completely. After the installation of this povidone iodine, there has to be irrigation of the ocular surface, but gently. A very over-rigorous irrigation is not recommended, because it is seen that overzealous irrigation of the ocular surface can dislodge the microbes which are kind of lodged in the corners of the fornices, upper fornix, lower fornix, and they can be dislodged. We don't want to disturb them and bring it into our sterile operative field. Now coming to the per-operative prophylaxis, that means at the time of surgery, what has to be done to avoid any increased risk of infection. So we have to take care of the surgical incisions, irrigating fluids, OVDs, and lastly, I'll discuss about intracameral antibiotics. And apart from this, instruments, as I told already, instrument sterilization is a separate topic. We have to be very careful about the instruments. Only sterilized instruments have to be used on the trolley of the patient, and there shouldn't be any cross-sharing of the instruments between two OT operation theaters or between two trolleys of different patients. So first, coming to the incision construction, the incisions should be valvular. Here in the diagram, we can see the incision is triplanar. If the incision is monoplanar, it's quite possible that after the surgery, if the apposition of the anterior lip and the posterior lip is not proper, then due to the capillary action, the preocular tear film with all the debris and whatever microbial load is there, that can be sucked inside the anterior chamber due to the capillary action. So incision construction is a very important step, and we have to make sure that the incisions are valvular. They also maintain the integrity of the anterior chamber and the IOP post-operatively. Secondly, if ever we have any doubt about if there is excessive manipulation or the incision size has to be enlarged due to any reason, and we know that it is not a self-sealing incision, it has to be sutured very meticulously, and the suture knots are to be buried properly so that they do not give a focus for the accumulation of mucus and the debris and provide a track for entry of the infection into the cornea or the limbus or sclera, whichever structure it is entering. At the end of the surgery, the hydration of the incisions is very important. The hydration again takes care that the incisions are sealed properly and there is no leakage and there is no passage of fluid either way. So this is important wound construction, important things to be considered in wound construction. Next, coming to irrigating fluids, the balanced salt solution which we use, it is a very important source, possible source of infection or contamination for the surgery. There have been several outbreaks of inflammation, specifically talking about TAS or infection, which can be tracked to the use of contaminated balanced salt solution or irrigation fluids which we are using. So it is preferred to have a glass bottle and to check the vacuum of the bottle before opening and connecting it to the drip set. The bottle before using should be inspected properly for any presence of any sediments, contamination, or turbidity. If the bottle is found, the liquid is found to have the fluid is turbid or is showing any sediments, as we can see here in this, there is a debris here, it's a floating thing, then it has to be immediately discarded, and the batch number of every consumable, especially the irrigating fluids, has to be noted. If there is any untoward finding on the next post-op day, it has to be tracked from the OT records that whichever patients have used the similar batch number of irrigating fluids, they have to be called up for follow-up and examined again. So, and one bottle for one patient, there shouldn't be any sharing of the things. And another important thing, some people add epinephrine or thing in the irrigating solution, which is not recommended, because sometimes the stabilizing agents in those injections can act as a non-infectious thing which can trigger severe inflammation post-operatively, leading to severe inflammation, that is toxic anterior segment syndrome or TAS, which would be discussed separately. We'll come to it later. So this is about the irrigating fluids. Second, coming to OVDs. OVDs, as we know, are very important for the surgery, and they are available as a sterile pre-filled syringe or a multi-use vial, which is sterile. So pre-filled syringe makes things very easy. You open one syringe, apply a sterile cannula and use it for one patient and then discard it. There should not be any sharing of these things between patients, and especially the cannula should not be interchanged or used in the next patient. So that has to be very carefully examined. And also, because it's a transparent syringe, it is a good practice to again examine the syringe and to see if there is any kind of debris inside it or not. If there is any doubt that there is some kind of, sometimes we see there are some green or shining fibers in the syringe we have seen, then you have to discard that thing and open a new fresh PFS. In case of multi-use vials, it is very important that the scrubbed assistant opens the vial and loads the sterile syringe and attaches a sterile cannula, and then places this vial onto a separate sterilized trolley, not keeping it on the same trolley for the patient. And later, when it has to be used after changing the gloves, it has to be used and it can be filled for the next patient. So this is the important thing which you have to take care about the OVDs. Now coming to intracameral antibiotics. So intracameral antibiotics, the rationale is that during the surgery, after we make incision onto the into the eye after the surgery, and there has been a lot of influx of a lot of things inside the eye, like instruments, fluids, and OVDs. In case if there is any microbial agent which has entered the anterior chamber, this antibiotic which is given inside the anterior chamber, remains there for a certain time, and it has a strong concentration that will able to kill all those infectious agents or to neutralize that infection. So that is the basic rationale behind intracameral antibiotics. So there was a large, first in 2006, there was a very big study carried out by ESCRS, and it was done using intracameral cefuroxime, and it showed that the use of intracameral cefuroxime at the conclusion of the cataract surgery drastically reduced the incidence of endophthalmitis in these cases. And after that, again, there was another study by American Academy of Ophthalmology that also showed that the use of intracameral antibiotics reduces the rate of infection. But however, there is again no worldwide consensus on this. Many people still prefer to skip this step. And coming to the choice of antibiotics, again, we need to have an antibiotic which is highly bactericidal, attains good concentrations inside the anterior chamber, has a broad spectrum activity against the desired organisms, mainly gram-positive, and remains in the anterior chamber for a longer time. Apart from that, it should have a low toxicity potential. So currently, intracameral moxifloxacin is used. The commercially available preparation, off-label use is being done. 0.1 cc containing 500 microns of moxifloxacin can be injected at the end of the surgery. It is shown that it achieves more than 10 times of the MIC, and it stays inside the anterior chamber for a limited period of time. During that time, it is highly effective against the microbes which have entered the anterior chamber. So now we come to the post-operative prophylaxis. Post-operatively, most importantly, we have to give post-operative antibiotics, and ocular hygiene has to be explained to the patient. Ocular hygiene explanation is a very important step. Sometimes in the busy schedules, the surgeons might overlook this, but it is a very important thing. Patient has to be clearly instructed that no touching of the eye. The eye drop installation should be such that the nozzle of the eye drop should not touch the eyelashes because it gets contaminated using that. And again, the patient is using the contaminated nozzle tip into the eye. So that should be properly explained how to instill the eye drops. After pulling the lower lid down, it has to be instilled in the inferior cul-de-sac from a distance without touching the eyelid skin or the eyelashes. There should be no water splashing in the eye, no kind of dust or fumes, anything should be entering the eye. These are the general post-op hygiene maintenance instructions given to the patient. And coming to the post-operative antibiotics, use of topical antibiotics is advised for up to 1 to 2 weeks, at least till the incision heals completely. It has been epithelialized. Once it epithelializes completely, there is no contact between the ocular surface and the anterior chamber. So the passage of things either way has been stopped. So that is very important to cover with antibiotics during that time. And tapering of antibiotics is not advised. It would produce antibiotic resistance, which is not desired. And the most prescribed drugs are 4th generation quinolones. Some people also prescribe aminoglycosides, but we have to be very careful about the ocular surface toxicity. And these drugs, we know, that provide coverage for most implicated pathogens like gram-positive, Coagulase negative, aureus, and strep, and have a good intraocular penetration. So post-operative antibiotics, earlier we used to see that some people used to prescribe an antibiotic and steroid combination we need steroid for longer time, 4 to 6 weeks. So giving an antibiotic steroid combination for 6 weeks is exposing the patient to antibiotic for 6 weeks, again, which is not helping with the prevention of emergence of resistance. So it is recommended that antibiotics can be stopped after 2 weeks, and a separate vial of steroid can be continued for as long as is required as per the periodic examinations of the patient. Now coming to the post-operative inflammation part, surgery is basically a trauma to the eye and trauma to the body, and body's response to any kind of injury or insult of trauma is inflammation. So inflammation is a normal finding after cataract or any kind of surgery. But there are certain patients who have a higher risk of inflammation or a more severe inflammation as compared to the expected inflammation. And these are the patients who would be having a longer operative time, extensive procedures, combined procedures, or a younger age. And these inflammatory findings we have to see on day one, examine the patient, and we have to see, assess, and then steroids are started. Initially, for first 24 hours, the frequency of steroid has to be more because that is the time when the inflammation is most severe. So you can give up to 2 hourly dosage on the day one. After 24 hours, it can be tapered to 6 times a day. Corticosteroids are also known to reduce the incidence of post-operative cystoid macular edema and help in the better visual acuity. The role of non-steroidal agents is documented. There are certain studies which establish a synergistic role of NSAIDs along with corticosteroids in the prevention of CME. So the patients who are predisposed to CME, like who are already patients of diabetic retinopathy, they can be started with NSAID. Or also there's another thing, there are certain patients who are steroid responders. In those cases, we would like to reduce or taper off the steroids quickly and substitute them or augment them with NSAIDs. So here is the role of NSAIDs. The commonly used steroid formulations here are prednisolone 1%, loteprednisolone 0.5%, difluprednate, and dexamethasone is also given in some places. When coming to talking about the post-operative inflammation, one very important entity, clinical entity, which has to be discussed is toxic anterior segment syndrome, which is known as TAS, also called sterile post-operative endophthalmitis or toxic endothelial cell destruction syndrome. It is basically a non-infectious acute post-operative anterior segment inflammation. It is caused by non-infectious agents which are introduced into the anterior chamber during the surgery. This severe inflammation causes toxic damage to the structures of the anterior segment, mainly and most importantly, the corneal endothelium. If the insult is too high and it is not controlled, the inflammation is not controlled in time, there can be permanent damage to the corneal endothelium, and it can lead to corneal decompensation requiring a DSEC or DMEC later. So about toxic anterior segment syndrome, how does it present? It presents quite early in the post-operative period, usually within first 8 to 12 hours, as compared to endophthalmitis, which presents after 2 to 3 days, usually on second or third day. And the inflammation is typically severe and limited only to the anterior segment. When we examine the patient on the slit lamp, we can see the corneal edema is diffuse, that it is limbus to limbus. There is no sectoral or segmental edema, as we can see in cases of any damage to the DM or DM stripping in case we have, then there is a focal or a segmental edema. In case of TAS, there would be diffuse and total corneal edema. AC reaction in the form of fibrinous reaction or hypopyon can be seen. There can be fibrinous deposits on the iris or over the IOL as well. The IOP would be normal or low. When we examine the vitreous, we can see there is a minimal reaction. In cases when the corneal edema is too dense to preclude any fundus examination, then a B-scan is a good idea to see if there is any involvement of the posterior segment vitreous or not. Smears and culture taken from these eyes are negative for microbial organisms. So this separates it from this kind of keeps us in safe that we know we are not dealing with infection. This is the conclusive thing to see. And this is just a slide, the common clinical differentiation between TAS and endophthalmitis. Timing of presentation, TAS is quite early in the first 12 to 48 hours, and endophthalmitis usually after second to third day. There's minimal or none pain in TAS. There would be severe pain in endophthalmitis, purulent discharge in endophthalmitis, while discharge would be watery in TAS. Lid reaction swelling would be very minimal in TAS, but very severe in endophthalmitis. Corneal edema would be localized or segmental in case of endof, but diffuse limbus to limbus in TAS. And examination of posterior segment is very important, as I just told. So now we come, what are the causes of TAS? First of all, if there is any breach or there is improper cleaning or sterilization of the instruments, it's some kind of debris is still attached to the instruments, or any cleaning agent remains attached to the instruments, and those instruments, if they are used, they can induce a severe inflammation. Balanced salt solution has been shown to have endotoxin contamination, and there was a major outbreak in USA. Around 110 cases were reported because of using a single batch of BSS, which was later after testing found to have an endotoxin contamination. That is why it is very important to document and inspect the BSS before taking it for the surgery. Specific IOL models also have been associated with outbreaks of TAS in the US. Again, in 2012, I think there was 10 cases because of a specific IOL model. And the polishing agents or the surface modification agents can induce or trigger severe inflammation. Preservatives in the form of BAK can also cause inflammation. So again, when we are talking about intracameral antibiotics, we know these are preservative-free antibiotics. It cannot be substituted with the commercial antibiotic having a preservative. So that is another important factor to be kept in mind while taking on the intracameral antibiotics. And as we discussed earlier, epinephrine or any kind of other things added into the irrigating solution, they might have certain stabilizing agents as bisulfites in the epinephrine. They are known to cause toxic anterior segment syndrome. So this was all about inflammation. And now coming to the, I think, yeah, we are quite on time. I'll just take another 5 minutes if it's okay, Dr. Paresh and Dr. Pranita. Then we can go on for the discussion. Coming to the IOP rise after surgery, the rise of IOP is because of inflammation, and it is a common finding. And these elevations are usually very transient and occur mostly in the first hour, and then there is a spike between 8 to 12 hours. But at the end of 24 hours, it is seen that less than 20% of patients or even lesser are documenting IOP measurement more than 26 or 28 millimeters of mercury. So any kind of IOP which is more than that is not normal. And there are certain eyes which are predisposed to have more rise in IOP. These are eyes with pre-existing glaucoma, eyes with a high axial myopia, poor pupillary dilation, elevated baseline IOPs, and having a pseudo-exfoliation syndrome. Other factors like intraoperative complications like a posterior capsular rupture, vitreous prolapse, IOL placement in the sulcus, long duration of the surgery, excessive tissue handling in the form of iris handling, non-dilating pupil, you are putting pupil dilator hooks and all, that can also trigger, that can release a lot of pigment and induce inflammation, iritis that can lead to increased IOP. Other times, sometimes, as we earlier had discussed, key HSV patients, if the trabeculitis is reactivated after the surgery, then it can lead to increased IOP. Then what is the cause of IOP? So these were the factors which may predispose the patient to increase IOP. Coming to factors, it is known that the elevation of IOP is multifactorial. There can be a pre-existing aqueous outflow facility compromise in patients. There can be retained ophthalmic viscosurgical devices. So this is very important factor during the surgery, which a surgeon has to take care of, that the viscoelastic devices have to be thoroughly and carefully cleaned from the angles, and especially the angle which is diametrically opposite to the site of injection. It is seen that whatever side port or the incision which you are using to inject the OVD, it goes mainly and kind of lodges mainly in the angle which is diametrically opposite. So it should be taken care that we sweep that angle very carefully, because if the larger the amount of the OVD remaining, that kind of chokes the outflow facilities and it can lead to elevation of the IOP after surgery. Retained lenticular debris, the release of pigment during the surgery, and inflammation, these are the causes which lead to raised IOP. So how did we prepare ourselves for that? So any known case of glaucoma or normal patient taken for surgery should have an adequate IOP control pre-operatively. Patients of phakomorphic glaucoma, which are having a very shallow AC and high IOP, should be taken under IV mannitol. It should be given to deterge the vitreous so that there is the lens can fall back slightly and it gives us space and easy maneuvering of the thing. Also, it prevents any disastrous complications like expulsive. So mannitol is a very important thing there, so that there is no sudden decompression of the anterior chamber once we enter the AC with our cataract incision. Glaucoma patients, all the anti-glaucoma medication have to be continued before the surgery, except the prostaglandin analogs, because it is seen that these lead to higher incidence of cystoid macular edema after the surgery. Many surgeons prefer to give pre-operative oral Diamox one night before the surgery and on the day of surgery. This is supposed to take care of, reduce the baseline IOP and further reduce the spikes of the IOP after the cataract surgery. And if we see that post-operatively, if the pressures are very high and we know that this is not going to come down immediately, decompression of the anterior chamber can be done in a sterile setting. the posterior lip of the incision can be slightly pressed and some amount of aqueous can be released. It shouldn't be sudden, it shouldn't be massive, so that we get a flat or a shallow AC. So that has to be done in a very controlled manner. So with this, I come to a conclusion of my talk. Thank you for your patient listening.
Thank you very much, Dr. Shilpi. It was a really nice talk from you. And I know you have covered all the aspects of pre-operative, peri-operative, and post-operative prophylaxis measurements for infection, inflammation, and IOP control. Very well said. And I so it is a comprehensive approach which has been given to the surgeon. You have covered all the antibiotics approach also, which is very required for the surgeon to give. And mostly nowadays, what mostly preferred antibiotics which are used, that has also been covered very well. My question is that, especially in pre-operative, when you were talking about endogenous endophthalmitis, I think very important part is dental treatment has to be asked to the patient.
Right.
That is very important, because nowadays these all aged patients, they have very common dental problems, and they are suffering from the dental caries, or they are going under the root canal treatments and everything.
Absolutely.
So they usually ask to us regarding when to get these treatments. So when they have caries or some ENT problems are also very important. So these are the two things which has to be taken care when they are going for the cataract surgeries. So I think so that has to be taken care, and we have asked then, is there any dental problem or ENT problem or any discharge coming out of the ear or anything? I think so that is very important.
Right, sir.
Yeah. One part in I think so IOP, what you were talking about. I think so one prophylactic measure which can be taken in intraocular pressure prophylactically in a pre-operative part is YAC PI we can do in some of the cases of acute congestive glaucomas, or when there is antechamber is quite shallow. And when you dilate the pupil, the intraocular pressure rises, especially in very high hypermetropic patients or those who have a very acute congestive glaucoma patients. Their prophylactic YAC PI, it plays a very good role because it circulates aqueous humor, and in the intraoperatively quite so maneuvering of the instruments, especially intraoperatively. So that also is a tool which we can use it, especially in all these patients, I think.
Yes.
Dr. Pranita, any questions from the students, those who are listening to us?
Yes, ma'am, first of all, it was a brilliant talk, and you have covered such an exhaustive topic, and every aspect has been covered. Just a few points that I would like to add is in the history part, as sir was saying that we should take history for dental history. We can also ask about specifically male patients about history of BPH and history of use of tamsulosin, because if we are suspecting a floppy iris, then probably in the pre-op period, we may like to atropinize the patient or put on hometropin so that we have a better sustained dilation operatively. Yeah. So other than that, we have the students, Dr. Debashish and Dr. Saksham. Welcome. Dr. Saksham, he is a graduate student at Guru Nanak Eye Center. He is a final year postgraduate at MEMC. And Saksham, would you like to ask any questions to ma'am?
Yes, ma'am. Thank you. First of all, thank you to Dr. Shilpi for such a detailed discussion of this topic. Ma'am, you discussed like while on table, we should apply the plastic drape is in such a fashion so it doesn't, the eyelashes don't come in a surgical view. So is there any role of cutting the eyelashes preoperatively?
No. Cutting the eyelashes won't serve any purpose because whatever the colonization of the microbial agent happens at the base of the root of the eyelashes. And when you are trimming the eyelashes, basically you are not disturbing the whole lash line or anything. The excess hair, it can be easily, it is a nuisance if it comes in your surgical field. If you have draped it properly and put a good speculum, the lashes won't trouble you. So trimming has no role. Earlier days, in fact, when I was a PG JR1, we used to go to the wards and you be trimming the lashes whole evening. JR1 was given that task. So nowadays we don't do that. The other important thing which you started the question could be the plastic drape. Why I said should be preferred over a cloth drape. First of all, we put a cloth drape and over it the plastic drape again, because the cloth fibers again can act as a tract which transmit because of the capillary action. They suck whatever is there on the skin and can transfer it, because that is made of fibers. Plastic does not have that. That is why the plastic drapes are considered superior to the cloth drapes. Right?
Thank you.
Anything else, Akshay?
And then
Yeah.
one more question, like
Prior to
for
the
HSV,
plastic drapes were actually introduced, that was the time when eyelash cutting was actually being practiced. Then later on, there are comparative studies that have been done which say that there's no difference in the rate of end of whether or whether you don't cut the eyelashes.
Trim the
Hence,
lashes.
so cutting of eyelashes does not reduce the risk of endophthalmitis. In fact, when you're draping such patients, when the eyelashes are cut, placement of drape becomes all the more difficult because they
Right.
don't get, stuck onto the plastic drape that you are trying to stick it to.
Right. The smaller hair would keep on popping out. The
Yes.
larger would be folded back neatly, and it will stick with the drape onto the skin.
And I think so
yes.
now in the present era of cataract refractive surgery, cosmetic purpose is also a very important part. I think so. Because younger patients are coming for the cataract surgery, and if you cut the eyelashes, then it will be difficult for them to
Cosmetic
digest
blemish.
that thing.
True, sir.
Right. True.
Yes, Saksham, you were asking one more question.
Yes, ma'am. You discussed about HSV disease of the cornea. So how long should we start the prophylaxis before of antivirals, and how long should we continue them for?
That is again a point of debate, but the standard practice which we follow here, any patient who has had a recurrent HSV disease in the eye, plan for a cataract surgery, or for that matter, any intraocular surgery, cataract or filtration surgery or VR surgery. The physiological stress and the post-operative steroids would trigger, the HSV virus goes and colonizes in the trigeminal ganglion. It doesn't leave your body ever. So any kind of local immunosuppression triggers the HSV again, so it can manifest in any way in the eye. So what we do is 5 days prior to the cataract surgery, we start systemic acyclovir for the patient, which has to be continued well up to at least 2 weeks to 3 weeks. And then you see the patient and examine. You're, of course, following up the patient regularly at periodic intervals. And if you see that there is no evidence of any increased inflammation or any reactivation of HSV, then you can stop. But 2 weeks is recommended at least. There is no need to give it for months or like we give for a actual HSV prophylaxis.
Thank you, ma'am.
Okay. Thank you.
Yes, Debashish. Dr. Debashish, would you like to? He's a postgraduate at AIMS Bhubaneswar. Which year are you in, Dr. Debashish?
Yes, ma'am. Myself. Thank you, ma'am. Good evening, ma'am. My question. Can you hear me, ma'am?
Yes,
we all can
Debashish,
hear
go
you.
on.
Yes, ma'am. My first question is, ma'am, like you have told about HSB, we have to give the money. First, you have told that before 3 months we have to, the activity should be, like for at least for 3 months it should be inactive. Okay.
Yeah.
In routine cases in government hospital, most of the we see a scarring present over the cornea. But that might be a sign of viral keratitis. But patient, most of the cases, they are not able to give the history that whether they have that actually they have that disease or not. Sometimes we ask whether you have redness or like in that cases, what should you do, ma'am?
Many a times, a lot of patients, especially from the rural background, and the government set up the patient which will come to you, they're having multiple nebulomacular scars or even leukomatous
Yes, ma'am.
scarring.
That
So then in that case, you have to decide whether it is a type of, because these are usually from the rural background, agricultural exposure, so they can have multiple type of keratitis which can lead to this kind of scars. It is not necessarily only HSV. Then you have to rely on your history taking and the examination of the eye. First of all, you check for corneal sensations, compare it with the
That is the
normal
most.
cornea. Reduction in the significant reduction in
Ma'am,
the corneal
any scarring,
sensation.
ma'am, like any scarring, it will reduce the like any.
It will reduce, but
It
then
will
you
reduce,
also,
whether
yeah,
it is HSV or not. That is not no.
again,
It will reduce the
then
sensitivity.
yes,
And
because if it is scarred, that tissue has been damaged in that area. So nerve endings have also been damaged. The sensations will overall be generalized, reduced. Okay. It also helps to ask about the laterality of the disease and the history of recurrences. If there is a very specific history of recurrences with the similar set of symptoms patient had, but most of these patients don't get treated, then you can ask if what there's a frequent episodes of redness, watering associated with glare in the eye, watering or sensitivity to the light. The recurrences are not very common in a bacterial or a fungal keratitis. If there is a very periodic history of recurrences for many years, then it mostly points towards HSV. So here you have to rely on your diagnosis making based on the history of the patient, right? And then you again clarify from the patient that was there any episode of pain, redness, watering in this eye within last 3 months, within the period of last 2 or 3 months. If yes, and you see that it does not look like viral, go ahead. But yes, if the history is suggestive of viral disease, then it's better to wait.
yes, ma'am. Ma'am, in case of any systemic viral infection like systemic herpes infection, in those cases, is there any role of like using antiviral for that before cataract or after cataract surgery?
Systemic viral infection means
Like herpes
Without
zoster,
ocular involvement.
you're
in case
talking
of
about
herpes.
BZV. You're talking about varicella zoster virus. Yes, again, varicella zoster virus can also be a very big comorbidity for the eye, especially for the patients in that age group. We know they are more prone to zoster, patients who are diabetic, patients who are old age, immune suppression also. So all these factors are inching towards each other in that age group, which is planned for cataract surgery. So if there are a history of a zoster infection, then too you have to start systemic acyclovir prophylaxis before the surgery, because you know the herpes zoster also affects the trigeminal nerve, that segment which
trigeminal ophthalmic branch of trigeminal.
Ophthalmic branch of the trigeminal nerve. So if it gets reactivated, it can lead to keratitis or uveitis or keratouveitis. So again, it has to be treated prophylactically with systemic acyclovir if there is a specific history of zoster. If it was severe enough, you can see the marks on the forehead of the patient. That is why preoperative examination of the lid and side of the nose and the forehead is also very important. But herpes zoster is one thing which history cannot be missed by the patient. If he or she ever had it, he would tell you, because that's a very
any role of topical antiviral, ma'am, in those cases?
Topical antiviral has no role unless you have a epithelial disease. Okay, if you have an epithelial viral keratitis, then you give topical acyclovir. Okay, acyclovir ointment is not recommended for stromal or endophthalitis or uveitis. Only, so no topical antivirals. All it will do is add to the surface toxicity. Yeah.
Ma'am, and another question is, ma'am, in case of like uveitic cataract cases, in those cases, for how many days before the cataract surgery, we should give the patient on steroid, or and for how many period the patient should be free of any uveitis? Well, generally we recommend 3 months, ma'am, generally in cases. But what is the period of steroid, and after any like before how many days we have to start the steroid for those patients?
See, the thumb rule is you do not operate a inflamed eye unless it is kind of a sight-threatening situation. So if it is a patient of uveitis, only after it has been controlled, you can plan the surgery. It is better to wait for at least a month if the patient has been quiet. And there is no data or any guidelines regarding the pre-operatively starting steroids. We don't want to start the pre-operative steroids just because we are reducing the immune status of the eye and predisposing to infection. But yes, these eyes would be more prone to post-operative severe inflammation. So you have to give a steroid cover post-operatively, which has to be maybe more frequent than the normal cataract, and even oral or systemic steroids might be required, depending on how your patient behaves on the post-operative day one. You have to assess and then add oral steroids if required. So it is not you have to wait for 2 months or 3 months. If it is anterior uveitis, idiopathic type of uveitis, then you can perform once it is squared. It is better to wait for at least 3 to 4 weeks so that the eye has any residual inflammation subsides completely.
Yes. Ma'am, another question is, ma'am, like I have seen one case where we have operated on a uveitic cataract case. The patient is activity free for more than 2 months. Suddenly after that cataract, the patient's IOP got very reduced. Like it got reduced. Then how to like in general, you told that in uveitic cases there is, or in glaucoma cases there is chances of rise in IOP. But we have also seen those cases like where there is IOP suddenly got reduced.
What
And
is what is the root cause of reduced IOP after surgery? Now let me ask you.
Well,
Why
like ciliary shutdown, like ciliary body functioning, ciliary shutdown.
If the aqueous is not going out, there is blockage of the outflow, then the IOP increases. If the production of the aqueous, it's a contained system, inflow and outflow. If the production of the outflow is compromised, then your eye will go into hypotony. Then that means you are pointing towards ciliary shutdown. So ciliary shutdown to treat chronically, that is, why does it happen?
Because I have no much idea, but that after that we start higher steroid, like generally we give Predford.
Basically, it is a kind of inflammatory shock for that organ specifically, so that it stops producing it stops the glands it stops doing its normal job. So you have to give a very strong anti-inflammatory in the form of steroids, oral or sometimes even IV required, to take care of the inflammation and bring that ciliary body out of its state of shock and start its production activities again. Okay, so these are two different ends of the spectrum. In one, you are going into ciliary shutdown, hypotony, and the other is inflammatory spikes of IOP. Okay.
Yes,
so that will be evident on the post-op examination of the patient. Did you mean this, or what were you asking?
Yes, that one only. But like how many days? It gradually increases that after a period after a period of 7 days. Like we cannot measure the IOP regularly. But can we measure the IOP regularly?
The key here is you have to follow the patient very closely. So you cannot call the patient after 7 days. These patients have to be called.
No, the patient was in ward only, ma'am. The patient, we kept that patient in ward only.
Have the patient Okay. So till the time the ciliary body starts functioning properly and the IOP reaches a sustainable level, the normal range, you cannot reduce the oral systemic steroids of the patients. You have to maintain that. Okay, you cannot let the patient. What will happen if hypotony happens?
Macular, CD, choroidal detachment may occur.
Choroidal detachments can happen. So we don't want the events to line up in that way. We have to control the IOP very meticulously, and you have to give a bolus dose of steroids initially and monitor patients. Ideally, if you have a ward facility, you have to monitor the IOP 12 hourly, morning, evening, round pay. You have to take the IOP, and then usually it comes out of the shock with the steroid, the strong anti-inflammatories.
In such situation, you can even give a posterior subtenon tricot injection,
PST.
which acts like a depot and gives a sustained delivery of strong steroids. In addition to the topical steroids that you give, and other than prednisolone, as ma'am already said, that we can even add on difluprednate, which is one of the strongest topical steroids. So you add on the strongest topical steroid. You also give oral steroids. You can give 1 or 2 shots of IV steroids in the early phase. And if required, you can even give a posterior subtenon tricot, because you want to load the eye with all types of steroid so that you recover the eye as soon as possible out of that shock.
Yes, thank you, ma'am.
Any more questions, Saksham?
I just want to ask Dr. Shilpi, is there any difference in the pre-operative prophylactic treatment when you are doing a triple surgery of penetrating keratoplasty with cataract surgery and IOL implantation? Is there any difference you are doing in the pre-operative measurements? or any treatment part?
If I'm doing a triple procedure, basically triple procedure means it's a open sky cataract surgery. So the stakes are very high. And if we are doing just PK, we just take out the cornea and suture it quite quickly. It would take 10-15 minutes or even 5 minutes to just put initial 4 sutures so that the globe is closed. Adding a cataract surgery, which is an open sky, prolongs the open sky or an open stage for longer time. And the biggest risk we are seeing here is expulsive choroidal hemorrhage. So in these patients, I usually I always give IV mannitol before the surgery. Surgeries have to be done under block. So block, as a rule, I always block my own patients and do not give more than 5 or 6 mm of block, because if you add more bulk of the volume of the LA into the orbit, it might also increase the pressure, and a proper ocular massage has to be given so that the pressures are okay. Pre-operatively, I prefer to give Diamox to the patient a night before and also in the morning. And so this is the most important thing. And also a very important thing is that you have to be very vigilant in looking at the reflex when you are doing an open sky cataract surgery. A very subtle change in the color of the red glow, fundal glow, which you are seeing, can be an indicator of an early expulsive which is going to happen. If at that stage you abort everything else and just put your thumb over the opening in the cornea and keep it there for 5 minutes, 10 minutes, and then again give IV mannitol, which can decompress the vitreous further. Then you go on quickly suturing the cornea over it, even if the lens is not completely out, or the IA has not been done completely, or IOL has not been implanted, doesn't matter. The most important thing there is to close the globe. You can always come back later and do a AC wash and implant the IOL there. But once it goes into a state of expulsive, then it is almost impossible to go back from there. So just these two important things, that quantity of the block has to be very regulated, a good ocular massage, IV mannitol, and pre-op Diamox. This is what I follow. Dr. Pranita, anything else?
No, ma'am. I think you very well described everything. Just out of that discussion, what came to my mind is to ask Devashish, how do you do ocular massage? That ma'am just mentioned that we do a good ocular massage. Can you tell us, how do you do a good ocular massage?
Ma'am, I've done ocular massage in post-trap to elevate the bleb, ma'am. On that case,
blocking the patient.
Post block, how do you reduce the IOP?
Ocular massage. Oh, that, yeah. But because ocular massage, I think that flat bleb, we have to elevate that bleb. For that, we have to.
No, don't go on CRAO and flat bleb. Just after giving a peribulbar block, why do you give a massage? First of all, what is the need of ocular massage?
To first to reduce the IOP so that it will distribute first the local anesthesia evenly, and to reduce the IOP. That after giving the block, suddenly that IOP raises, no? So that's why we have to massage so that the IOP of that globe will decrease, and we can do surgery.
How do you do the massage?
And that mostly to distribute that
Saksham, would you like to let us know how to do the massage?
Rule is first, basically, we don't have to press for a long duration because it can cause compression of the optic nerve and lead to further damage. So basically, usually we use two thumb techniques or two fingers, and we press ideally the duration of the massage should be around 30 seconds only, not too much vigorous massage should also not be done. So around for 30 seconds with the not continuous pressure not applied for more than around 10-15 seconds.
Off and on, basically.
Off and on.
15 to 20 seconds of pressure and 10 seconds of release, because if you continuously press, your ocular blood flow is going to get compromised. And, especially in glaucoma patients, you can have a macular snuff out, and you don't want that to happen. So 20 seconds press, 10 seconds release. And if you're doing a hand on hand, you're placing one hand over the other, then blanching of the nail beds is the amount of pressure that you just want to apply, not too much, just that your nail beds blanch is the amount of pressure that you want to deliver. And if you're not doing it with your hand, what are the other options to give ocular massage to reduce the pressure?
Using eye shield, like eyeballs are there. Eyeballs which we
What
can
are the
place.
eyeballs? Name of the eyeballs?
Shield means you are protecting. You have to put a weight on it. It's not
Okay,
the eye.
not eyeball.
So you have a super pinky ball that you can use, or you even have Honan balloon catheters that were used in the past that could have graded pressure application. You could have actually measured how much pressure you want to apply with the help of the Honan balloon catheter. But currently, I think everybody is using the super pinky ball or giving digital massage. One more thing, like in the pre-op preparation, ma'am, what I could recall was that when you're operating patients in bulk, like you have a case list of more than 10 or 15 patients, it is always wise that you get the patient's mark, the eye that you want to operate. A pre-operative marking of the eye is essential.
Very important.
Yeah, you can either use marking pen. You can use a marking pen to create a cross on the forehead, or even some people use a micropore tape to create a cross on the side that you want to operate. Because when you're operating in bulk 20-30 cases and you have patients with similar names coming up on the table, you don't want IOL surprises, you don't want wrong eyes to be operated. Pre-operative marking of the eye is something which is very important. And wearing of a cap for all patients that come into the OT so that all the hairs are covered up and you don't want the hairs to be coming up in the operative fields. So I think these are the 2 points that I just wanted to add.
I think so. Some of the NABH criteria are also there, as we have NABH accredited centers. I think so in CFS, most of the centers are NABH accredited. So, like, patient has to wear
No street clothes for the patient.
all the new clothes and also the socks and everything. What we are
Covers.
Shoe covers, OT clothes that they cannot come in home clothes. They have to wear a cap.
And also
to the patient
just
in right or a left hand. So by that also we identify that right eye is operated or left eye has to be operated, and patient is wearing absolutely covered cap and everything. And when we very important part is that when assistant is painting the patient's eye, then he or she always asks the patient's name, what is the name, which eye has to be operated, that has to be confirmed and everything. So I think
cross-checking. That is
Yeah.
important.
Without the file of the patient, never take the patient to the OT. The file always has to be there.
Exactly.
You ask the name of the patient and you cross-check with your assistant that the file matches the patient's name. The eye matches your plan, the eye that you're draping.
Check the IOL
Check
before.
the IOL. Next, next
Power
you check
of the
IOL.
Our checking of IOLs too. I think so. These are
The
very
most important steps before you start, make your MBR entry. Check
Yeah.
your eye, check the patient's name, and check the IOL power.
very
One more thing just came to my mind as Dr. Pranita mentioned mass surgery. So not in an institutional setup, where in other setups where you are doing a bulk of surgeries like CAMS or something, it is very important to be more meticulous there as per Government of India guidelines or the NCPB guidelines. Not more than 25 surgeries per surgeon in a 4 hours of surgical span. No matter, you don't have to be a superhero there finishing one case in 10 minutes and then just doing, because all those things can lead to certain lapses. Also changing the gloves, and even NABH recommends scrubbing again in between every 2 patients and cleaning of the entire OT. I know there are a lot of logistic problems in this. It cannot be followed, but still basics like changing the gloves in between the surgery, changing the trolley, the sterile sheet and everything. And the important things which sir mentioned, like the patient should not enter the OT in the street clothes, the shoe covers or the feet covers are very important. And the marking of the eye is of utmost important. And before you touch the eye of the patient, before starting the incision, ask the patient his or her name and cross-check once and for final time and check it with the file. These things, if you start inculcate in your practice right now, will go a long way. Then
you will not fall into any medical legal complication.
Very important.
Absolutely not. And I think so. This is very common human error which can come across. So I think we should practice it day in day out. Always.
And since a lot of surgeries are also done under block, so it is important that whenever you're blocking a patient, if you have an anesthetic cover, that is always better, because the risk of vasovagal and cardiac issues is something which can happen. So other than the patients that are already having a pre-existing cardiac issue and you plan the patient under cardiac monitoring, the routine blocks should also be done, under a background cover of anesthetist. At least you should know that the anesthetist is somewhere around. If that something goes wrong, you have somebody to take.
That age group of patients is very vulnerable to any kind of systemic complications. So a physician or an anesthetist supervision is very important.
Very important. Very important.
And if you are, blessed enough to work in a OT where you have these available, then nothing like that.
I think so. Anesthetic part is very important because sometimes in topical also patient go in a vasovagal, and sometimes you have to give some relaxing injections and everything because they are.
That is why, in short,
claustrophobic environment.
after the surgery, never make your sorry, sir. Continue, please.
Claustrophobic environment is created, so patients are very much anxious, and when
in prolonged surgery, keep talking to the patient.
true.
Forget that you don't talk to the patient. Keep talking to the patient. You know that the patient is fine.
Right, true.
And at the conclusion of the surgery, never make the patient stand up immediately and leave. First, make them sit properly, make them sit with their feet down because there is also some orthostatic hypotension, and make them move their toes, and so that they are properly standing, and ask them if they are okay, they are not having any dizziness or vertigo or anything. If the patient complains of anything like that, you get in a wheelchair for that patient and get them wheeled out. So that is very important to take care. Sometimes you've done a fabulous cataract surgery and the patient gets up and he falls, and then you end up with severe injuries or any kind of other issues, which is totally avoidable by just taking care of these small things. And a block patient has to be patched for 4 to 6 hours. Nowadays the thing is कि you come in just kala chashma laga ke bahar ja rahe hain, so you have to instruct the patient that the patch is not to be removed before 6 hours, or they can come tomorrow morning, next morning to the hospital to get the patch removed. If they have to remove on their own, at least 6 hours, because that is the time when you assume that the effect of the anesthesia has totally waned off and the blinking of the lids has resumed properly. So there is no risk of exposure to your ocular surface and the incisions, which are very fresh and non-epithelialized. So that is one important thing. Nowadays, most of the surgeries are done under topical. So doing a block surgery, you have to keep this in mind. Right?
Right. True.
I think we've had a wonderful session and a wonderful discussion. And sir, any more comments?
Very good topic has been covered by Dr. Shilpi, and I think so. This is very helpful to all the budding surgeons, those who are going to come up now, and I think very important for a surgeon. I think so. This is the first and foremost thing for a surgeon to learn, that when he enters in the operation theater, he should learn first that how he has to prepare himself before he's going to do a surgery, right? So I think Dr. Pranita, I think this is a very good topic which has been covered, and Dr. Shilpi, excellent presentation, and I think so very good coverage of a topic. Thank you very much.
We had a very fruitful discussion, and our students should benefit from that. Thank you so much.
Thank you, ma'am, and thank you, Debashish. Thank you, Sakshan, for joining in and giving us time. Okay. Thank you, ma'am. Thank you, sir. Good night.
Okay. Thank you, everyone. Good night.